YouTube, welcome to Dr. Vibe's Learning Point. In this video, we'll study about a given condition that is hematuria. So first of all, you should know what is hematuria. That hematuria is the presence of blood in urine. Now, you can classify this into various categories. First is the visible and the non-visible hematuria. Visible is that you can see the blood in urine that is coming out, and non-visible hematuria is when you do a routine examination and that shows more than equal to 3 RBCs per high power film. Now let's see, according to the timing of hematuria, the different classifications. So if the blood is coming out in the initial part of the voiding of urine, or is it coming in the terminal part, or is it throughout? When you void the urine, the blood is present. So if it is initial, that means some problem is there in the urethra. If the blood is present at the terminal part of voiding of urine, then that means it could be from the bladder neck or prostatic urethra. And if it is throughout, the blood is coming throughout the voiding of urine, then it can be problem at anywhere. Like it can be in the kidney, it can be the ureter, it can be in the bladder, it can be in the urethra, and any part of the upper urinary tract. Now, according whether your hematuria is associated with pain or not. So most of the hematurias are painless, but it can be associated with pain. One, if there is UTI like cystitis, that means inflammation of the urinary bladder, and urethritis, that means inflammation of the urethra. Or it can also be when there is a stone or a calculus in the ureter. Now, depending on the quality of blood, whether it is fresh blood or it is cola colored. If it's cola colored, it is from the glomerulus, and if it's fresh blood, it is from the lower tract bleed. Now, most important thing is that you have to know what can be the causes of hematuria. So, you divide this into glomerulus, into ureter, then urinary bladder, and finally the urethra. Now, how will you remember the glomerular causes? So, for that you have the mnemonic vitamin CD. V is for venous or vascular lesions, that is renal vein thrombosis. I is for infections. It can be glomerulonephritis. It can be tuberculosis involving the glomerulus. Then T is for trauma. Vitamin A is for autoimmune conditions like IgA, nephropathy, Alport syndrome. Then M, that is metabolic conditions. It can be glomerulonephritis. It can be follicular segmental glomerulonephritis. Then I, that is for iatrogenic causes. N, that is neoplastic, the tumors involving the renal cell carcinoma or the transitional cell carcinoma. Then C, that is congenital causes like AV malformations. And D, that is for drugs and the toxins. Like other causes you can write down, for example, papillary necrosis. Right. So now let's move on to the causes of ureter. So there can be stricture in the ureter, or ureteric stone, or ureteric calculus, or ureter malignancy. Then you have the urinary bladder. So urinary bladder, there can be inflammation of the urinary bladder, that is cystitis, or a malignancy, or a trauma of the urinary bladder. Then there can be, radiation cystitis, right? And finally, you have the urethra, in which there is urethritis, stricture formation, diverticulum or trauma. So any of the tract, just remember, you can have a trauma there, you can have inflammation of that part, you can have a stricture or a diverticulum or a polyp in that part. Now finally, what investigations you will do, or how will you manage the case? Management is, diagnosis and investigations. Diagnosis involves the clinical diagnosis and the examinations, and finally you have the investigations. So investigations, first obviously you have to confirm that this is hematuria. So for that you do a routine examination where you will find RBCs and WBCs. You do a microscopic examination where you will find the casts. Then you go to urine cytology to find out if there is any malignant cells in urine. This is usually done when the cause is, associated with some malignant underlying malignancy. Then you have the imaging, in which you have the USG, the CT scan, which is the non-contrast CT scan. Then you have the intravenous urogram, and finally you have the MRI or the CT with contrast. Okay, so basically first line obviously is USG because that is cheap and commonly available, and NCCT is done if calculi is suspected in either ureter or urethra. Finally, you do a cystoscopy. This can be both diagnostic purpose as well as a therapeutic purpose, and cystoscopy helps you to look inside the urethra and the urinary bladder. Now finally, you can remove the bladder tumors by transurethral resection of the bladder. This is called as TURBT. This is one of the management that I can say you.